Let's bring the Senate Health and Human Services meeting to order. That was Live Like You're Dying instead of being kind and gentle today, but I'm waiting on the red Solo cup pretty soon. So that's where we are. We're going to open us up in our prayer today. Senator Orrock, if you don't mind doing that, you're on mic number 12.
Thank you, Mr. Chair. I'm live. Thank you so much. As we bow our heads in prayer, we come together today seeking common ground and divine guidance as we fulfill our duty to make sound and just decisions in the best interest of all Georgians. Thank you for bringing us together, and we pray for guidance and wisdom as we weigh the decisions before us today. Amen.
Thanks, Senator Orrock. We appreciate that. We had House Bill 181 on the agenda today, but we're still working on that amendment, and we're not in full agreement on that, and so we're going to postpone that till next week. And we will be meeting next Monday at 2 o'clock, and we have a department bill also we'll be doing at that time. So we're going to go straight to the Trauma Care Network, and I think we have a good story there. They're supposed to present to us periodically, and I think they have some good news. So, Dr. Ashley, how do you want to do this? Is this going to be, we got slide presentation and we got handouts, and you want to go to the podium? You want to come here? Okay, that'll be fine.
Thank you, Chairman Watson. Can you hear me okay?
I can. Let me just give a little bit of background. So, Trauma Care Network came into existence, help me out here,
2007-8.
2007 to 8 legislation.
Senate Bill 60.
Senate Bill 60. The funding of that had to do with the super speeder bill that has been designated and is now, I think, fully funding all the money in the super speeder tickets do go to the Trauma Care Network. We also, with Chairman Mullis and I, passed a constitutional amendment relating to the excise tax relating to fireworks, and that is by constitutional, goes into that also, which is a much, much smaller portion than the super speeder ticket. Good news, bad news. But I think your statistics, and this is what I want our committee to know, we're getting feedback today, and we have been getting feedback every year or so from the Trauma Care Network relating to how their progress has been. Because we started off at a point in the state of Georgia compared to the rest of the nation not necessarily so good. So I'm not going to steal any thunder, but I do think I think it's important for us all to hear. So I've heard all the data. It was Dr. Dunn and Dr. Ashley presented it to us, and we're going to have an abbreviated version here. But thank you for being here. We really appreciate that.
Thank you very much for that introduction. I have two colleagues with me today, so I'll go first here to Dr. Dunn. You want to introduce yourself?
Sure. Just Jim Dunn. I'm a trauma medical director in Savannah, Georgia.
So Dr. Dunn is down there with me in Memorial. He runs the trauma program, the residency program.
I am not in charge of the residency program. I was in charge of the fellowship program, but I turned that over to one of my colleagues because trauma is occupying a large portion of my time.
For 7 years?
9 years.
9 years. Been on the trauma commission for
About 8 years.
about 8 years. And thank you. It does help if my mic's on too. So, okay. All right. Just a little further background.
Yeah.
And he's the vice chair of the Trauma Commission, representing the commission today. And Liz?
Liz Atkins, Executive Director, and I know I present in front of you all, have done that before. And I've been with the Georgia Trauma Commission since about 2019, and all my experience has been in either critical care as a nurse or trauma center administration. So I'm the brains behind the beauty here next to me.
Thank you. go ahead.
All right, well, I'll go ahead and get started. You have the paper copy of the presentation, or should have there. Started on this page here, and I believe the slides will be projected as well. So as Chairman Watson said, this is a time to celebrate. We do have some asks that we need to talk about. But first of all, as I come every year to talk to you all, I really emphasize the fact that this is where the clinicians such as Dr. Dunn and myself and the legislature come together. And I want to show you today what I'm very excited about, what we can do when we work together. Senate Bill 60 was, obviously this is home turf here. Senate Bill 60 was created because we had a trauma issue. The death rate was not what we wanted. There was not enough trauma centers. The centers that we had were threatening to drop out of the system. There was no funding at all. And then through the great legislation that came from Senate Bill 60 now in code, we've been able to turn that around. So with that introduction, and on the slide here, the graph, you'll see that when we took over about 7 or 8, you can see the number of patients that were critically injured. These are not minor injuries. We only looked at patients that had a 10 to 15% chance of dying, so very severely injured patients. Only about 66 to 70% of those patients were going to trauma centers. There was not a network. They would be taken care of in community hospitals that maybe didn't have trauma teams, and the care was really, we just didn't have enough resources. But through education, over the last decade or so, through increasing the number of trauma centers, we've now increased that number of patients that if you're critically injured, 93% of those patients are making it to the appropriate trauma center. So that has increased access, and I think will lead us into the next slide. You can see when we took over or were created by this body, you can see the teal-colored line there is the death rate. This is CDC data. You can go on your computer and find this data. There's nothing, the commission doesn't own this data. And you can see in 2003, the teal-colored line is the national average, the United States average in death per 100,000. And so on the y-axis there, it was about 56 deaths per 100,000. And you can see in orange and sort of red-orange, the southern region and Georgia were both 16% above the national average or worse than the national average as far as the mortality. And our job was to build a network to try and bend that curve down. And if you look at 2019, going all the way across the page, you can see now Georgia in orange is 6%. I don't have the percentages, but it's 6% below the national average. And the southern region, the southeast region, is still well above the national average or worse than the national average. So we've gone, to put it in very straightforward terms, we've gone from 16% worse than the national average to 6% better than the national average. And that's a time for a victory lap for all of us. We didn't do this as clinicians by ourselves. We couldn't. You couldn't do it by yourselves. As legislators, we had to work as a team. And through that legislation and our hard work, this is really a time to celebrate. So it's something we should all take pride in. We'll get into some details in a minute, what that means as far as patients and other things. Turning to the next slide, you see we're going to talk just a minute about trauma center readiness costs. I see some new faces on the committee, so I'll spend just a second to tell you what I mean by that. Next slide, please. Trauma center readiness costs are the costs that the trauma center incurs before they ever see the first trauma patient. It's not lack of insurance, or it's not partial payments. It's basically costs that you have to have, all the things that you have to be a trauma center to have in place 24/7. That's what we mean by readiness costs. And so the commission over the last 10 years or so has really studied this because there's not been a lot of good data nationally, and legislative bodies across the country have struggled with that number. What is that number? How much funding do you need? What's fair? What's reasonable? What's real? And so we realized that you needed good information, and we've spent the last several years really collecting that data and analyzing it. Next slide, please. And you can see here, this data we have now for the level 1s and level 2s. We can tell you what the true conservative audited readiness costs are to have all those things in place to be ready to go 24/7 before they see the first patient. For level 1s, it's 10 million. For level 2s, it's 4.9 million. And you can see the most significant cost, as you might expect, is the medical staff, because there's a very long list that I didn't include here of various surgical specialties, medical specialties, and equipment that you have to be a trauma center. Next slide, please. After we tackled the level 1 and level 2 data, we moved to the level 3 and level 4 centers, and there was absolutely no data in the literature on 3s and 4s. So as we've presented this data at the national trauma meetings and published it in the Journal of Trauma, we've received tremendous feedback because people are wanting to know these numbers. And fortunately now for our level 3s, the cost for readiness is 1.7 million, and level 4s are 81,000. That's an important number to know because level 3s and level 4s are usually in rural areas. Level 1 trauma centers are really the most resource intensive, if you will. Level 4s are more of frontline stations, sometimes critical access hospitals that really see the patient, maybe do a few minor procedures and then transfer, but they're very important to the foundation of our system. Next slide. I won't go through each number here, but just to give you an idea of some of the budgets, you can see back in 2008 and 2009 when we were created. At that time, Governor Perdue, the system was in chaos. There was not enough trauma centers. The centers we had were threatening to drop out. So they created the commission and then put $58.9 million in as a one-time funding source. And you can see there our readiness costs reading across that top line were about $40 million for the centers we had at that time. And again, this is 2008, 2009 data with limited trauma centers. And we were, with the funding we had, we were able to fund about $23 million, and that came out to be about 58 cents on the dollar. And that was sort of a sweet spot that seemed to say, well, it didn't seem, it did stabilize the system. People decided not to drop out, and we were able to hold the line where we were and then go and recruit other centers. However, over the years, you can see dropping down to the bottom in 2022, our budget now with the two funding sources that Chairman Watson mentioned is about $22.9 million. That's pretty consistent. You can see our level 1 and level 2 readiness costs are $109 million. We're able to fund about $8.7 million, or about 8 cents on the dollar. So you can see we're not able to fund a lot on the dollar with our readiness costs. 8 cents is all we can do for the 1s and the 2s. If you turn the page, next slide please, you can see we have data now on the level 3s and level 4s as we've become more sophisticated and have been able to collect that data. And just if you look at the bottom line, 2023, you can see that our budget again is $22 million. We have 5 level 3 centers, 5 level 4 centers. Their readiness costs are about $14 million combined, and we're able to fund about 6 cents on the dollar. So again, that 6 to 8 cents is where we're sort of stuck. Next slide. If you're a graphic person, we put it in this format. Sometimes the numbers are a little hard to keep up with. And you can see our funding in orange down at the bottom has held pretty consistent or pretty constant since that initial infusion of funds. But the readiness costs have continued to rise, and there's just at 2023 a rather huge gap. You might ask, why is there a spike, every few years in that teal line? That's when we do the surveys for readiness costs. It's a very laborious, time-consuming, audited process, and it's really too much to do every year. And as I said, it's an audited process, so it's not just hospitals turning in dollars. It's scrutinized data. So we only do that every 3 or 4 years or so. Now, turning to the next slide, please. Talking about performance-based payment. When I come and talk here, I like to make sure that you know we don't like, the commission doesn't like to be considered a bank, that we just pass out funds that we're fortunate enough to get. We want to make sure those funds are going for the right processes and that there's accountability. Next slide. If you look at the graph on your far left, the readiness funds that we give trauma centers, you see in 2010 on that graph to your far left, we only required 3 metrics or three things that you had to do to qualify for your funds. And now we're up to 22 different metrics or 22 different measures that you have to meet before you're eligible or before you can receive all of your funds. If you look at the graph on the right, you can see in 2010 only 10% of your funds were at risk. And now we've increased that to where it's 76% of your funds are at risk. In other words, if you don't meet the metric, most of your funds are held accountable for you to step up to the plate and make sure you meet all the metrics. So we like to, and this has worked well. This has helped our trauma centers stay on track. And this is one reason that we think we've bent the curve down, because we have accountability and we keep everybody in the game. Next slide. Just very briefly, most of my talk is on readiness, and you'll see why in a moment, but I will mention uncompensated care. Next slide. Through Senate Bill 60, that's our Bible, and it tells us that we have to fund some readiness costs and we have to fund some uncompensated care, and that's what we do. And so we put some funds into that silo or into that bucket for uncompensated care. And I didn't include all the numbers here, although we can have that at your request. But you can see, again, the orange line at the bottom where we run with our funding. And you can see over the years the uncompensated care costs have continued to rise. And in 2023, we were able to pay about 10 cents on the dollar for those costs. Next slide. And this just shows you over time. You can see when we had the initial insertion of $58.9 million, we were able to fund about 61% of the uncompensated care, and now we're able to fund only about 10%. So those numbers, it's funny how they run together. When we had that amount of funding, we were funding right about 60% of uncompensated care and 60% of readiness, and now we're funding about 10% of both, 8 to 10% of both. So they tend to run together. Okay, next slide, please. This is just putting it all together so that you can see all the costs that are associated with it. If we walk through this for readiness costs, the level 1 and level 2 centers are at $109 million. The level 3s and level 4s together are $14 million, for a total of $123 million in readiness costs. Looking at uncompensated care, you can see, I don't have time to go through all the calculations and everything, but just to mention it briefly, charges that are submitted for uncompensated care by the trauma centers are $659 million. We all know that charges can be elevated. And we're obviously well aware of that, as you are on the commission. So through our process, we back out or only allow $70 million of those charges. So we're pretty tight, if you will, or pretty judicious with the way that we look at the charges and the data. So there's about $70 million that are the hard dollars. And if you put the $70 million with the 123, the total trauma center costs are $194 million. Okay, next slide, please. Now looking at age-adjusted injury mortality. Next slide. As we come down to the end here, I'll end on the next few slides. Going back to this slide, I told you I would come back to that as to what that meant. It means that we moved from 16% worse than the national average, as I said, to 6% better than the national average with our death rate. And what this means human-wise, and taking it off the graph, that's 1,803 Georgians that were saved in 2020 that would not have been saved. That's what that change in percentages means. So those are real lives that family members came home that were not expected to. That we could stop there, but I know that you're under tremendous scrutiny to the citizens of Georgia. to the taxpayers, you know how you use the funds, and you're held to a very high standard. So we tried to look at this from a business model as well. What does that mean? So next slide. We took the patients that were saved, the 1,803, and we looked at the ones between 18 and 64 because those are working individuals and those individuals pay taxes. So if we can save their lives, not only get them back to their family, which is the most important thing, but if we put our business hat on, what does that mean for the economic impact of Georgia? And if you look at the left, the red bar, you can see if we looked at the income that was saved, the personal income in 2020 on those patients, this is lifetime now, lifetime income that they were able to generate, it would be $1.3 billion. If we looked at the orange bar for, saving those, looking at disability, because we know for every death there's about 2.2 patients that have serious disability. That was about $4 billion. So overall in the black bar, that was $5.4 billion in lifetime personal income preserved by saving those patients' lives. Now, if we look a little further to the shorter bar graphs, this is tax revenue. What does that mean to the state as far as where you sit and you have to keep an eye on and be the fiduciary of the state funds? That translates into $636 million in lifetime tax revenue preserved through those individuals. Next slide, please. So we didn't really, Dr. Dunn and I, being trauma surgeons, didn't really know if that was good or bad. So Chairman Watson educated us and said, well, we could look at the Savannah Harbor. We actually have things that we look at up here on return on investment. And so we dove into that, and sure enough, we found data on it. And so return on investment for the Savannah Harbor here is about every dollar spent generated about $7 or return on investment. Our return on investment is 1 to 22. So we thought that we had passed that metric, or that would be a positive finding for our return on investment. So what we would propose or like to say is that this is not necessarily an expenditure with the funds that go to the Trauma Commission. We really need to change the way we think of things. At least when we went through this exercise, Dr. Dunn and I and the commission, it started to dawn on us and that really this is more of an investment. It saves lives, but it is also saving tax dollars, and we should change the way that we really look at these kind of funding mechanisms. It really truly is an investment, and I think this was sort of eye-opening to us as we went through this exercise. Next page. So our stabilization proposal. Next page, please. I think I only have a couple more slides here. Is the following, and this sort of sums it up. I won't read the whole slide to you, but basically you see the level 1, 2, 3s, and 4 trauma centers. We have 34 now. That's double where we started, or about double. You can see our total readiness cost down there in bold at the bottom of the slide is about $122 million. So our proposal is, I don't think it's fair to the state, and I don't think it's economically possible to say the state can afford or pay 100% of readiness costs. However, what I think the state's obligation is some number. I don't think it's fair to have all the private sector or the trauma centers bear that burden as well. So where does that come? We thought that a 50-50 split, being somewhere in between, sort of going along with some of our history, seemed to be a reasonable place to start. That would be $61 million. So our ask is $61 million to be infused into the trauma system as an investment to save more lives, to increase the number of trauma centers we have now, specifically really in level 3s and level 4s in North and South Georgia, to feed those 1s and 2 centers to really continue to bend that curve on down. We also need to think about saving the centers that we have. I think we're all well aware of the Atlanta Medical Center closing up here and how that sent shockwaves through the community. Even as big as you are, even Atlanta is not safe from these kind of disasters. So with that being said, Chairman Watson, I'll stop there and be happy to answer any questions. Thank you.
Thank you, Dr. Ashley. We sure appreciate all of you coming, Ms. Atkins, Dr. Dunn. I think the bottom line is that, it's been a great return on investment, and 16% for all of Southeastern United States, of which we were part of, and now Georgia's alone at 6% better than the national average, and the rest of the Southeastern United States needs to sort of follow our lead from that perspective. And it's not been all about money. It's been a lot about training, residencies, fellowships, and publishing data, and holding, your slide there relating to the 10%, holding them accountable up to wherever percentage we are now.
76 now.
76% money at
76%.
risk.
So they don't get the money unless they meet the criteria. And I think that's a good thing, because as this committee's heard me say many times that, quality, drives price. And the fact is that because the increased quality of care you're giving our trauma patients, the number of lives you're saving, you're driving down, price and burden on our society, and specifically lives, right? Let me open it up for questions. Senator Orrock?
Thank you, Mr. Chair. Thank you so much for your presentation.
I'm going to interrupt you just for a second.
Certainly.
I don't want to filibuster on the questions, so we got folks who've got to catch planes, and we got another have another bill.
That's
So
right.
if we can be brief,
Yeah.
and thank you.
Thank you so much. Thanks for the great data. How do we compare with our sister states around us in terms of the number of trauma care systems that we've stood up? I've heard things from South Carolina that they're outstripping us, but do you have data on that? Because what I've been told is that we are far beneath the numbers that some other states have of trauma centers. I just wonder if you can validate that or
We
correct
actually,
me.
we're looking at those numbers, and I'm going to ask Liz, do we have the results back yet? We actually asked that question to set up a graph with the states around us, actual numbers, and I just don't know if that's back yet.
And I know, Senator Orrick, that was of particular interest to you all in the Senate Health, the special study committee that looked at recruitment of rural health
right.
providers. Yeah. So we still are putting that together. It's hard to know. I think for us, we can see where there's clearly a need, where there are citizens that are not served. That part is hard to tease out for other states. You can look at sheer numbers from the states. That is certainly available typically on their websites or on the American College of Surgeons records what the numbers of centers are, but
Do you
How do
know
we
the numbers?
compare then, if you've looked at
yeah.
them?
Numbers.
I think
We have fewer, don't we?
yeah,
Yeah.
we have fewer, but in certain areas, we certainly have a more of a need. And if you look at South Georgia, we're much more underrepresented in that area. I think it's pretty common. We're working with the American College of Surgeons Committee on Trauma because they're pushing rural now too, because they recognize that this is an untapped area and we need to figure out how to fix this for everybody across the nation. So I think other folks struggle with those areas where there are no options, and as your committee found out, the transportation as well is an issue.
That's right,
so.
because I heard the Charleston had 4 trauma centers in Charleston, South Carolina, compared to Atlanta. We're behind them, but, yeah.
All right, Senator Kirkpatrick.
Thank you.
Yeah, thank you for your presentation. For those of us that are visual learners, for years, you guys have given us a map that has all the centers on it, so we can see where the gaps are. Can you send us that?
Yes, we can.
Absolutely.
Yes.
Yes.
Yes,
Thank
we
you.
do have a brand-new map hot off the press, so you
perfect.
can see,
Okay.
and it has the circles around it that shows you the hour drive time, which I think will help us. Yeah.
Senator Brass.
Thank you, Mr. Chairman. Dr. Ashley and team, thank you all for being here. Dr. Ashley, you probably don't remember this, but my sister graduated from your program about 6-7 years ago.
I remember.
And Dr. Elizabeth Allman, and she says hello, by the way. But anyway, speaking of the map, you being a great advocate for trauma centers, I think you presented a map at that graduation showing everyone. And one thing I did notice then, and I don't think it's been changed since then, of the trauma districts, I believe the trauma district we lie in over in Noonan, Coweta County, west side of the state, I don't think we had a trauma center at that time. So my couple questions. One is, what do we need to do to get one in our trauma center? or trauma district. Two is on that uncompensated care. If we were able to reduce that number, would y'all still be requiring that 50% match, or would that number be able to come down?
Well, I think it's all, it's all how you look at the pie and all the money. What we thought, and this is open for discussion, money's money and the pie's the pies. There are only so many pieces in it. What we thought, this was our thought process, is that we could ask for funding and try to tighten up that curve in uncompensated care. We have good data. We monitor things. We're pretty sophisticated in our analysis of that. But it's a little harder. We have really super good data with the readiness costs, and we thought that was a little cleaner to come and ask for that piece. And it's a little cleaner for the hospitals. It's a little cleaner for you all to monitor and for us to monitor. And then it allows me, if I come back and I say, we are bringing on 3 new trauma centers in South Georgia or North Georgia or wherever, Noonan, and I can look to you and I can say this is exactly what it costs, and we've agreed that X amount or percent will be funded by the state. It helps you plan and do a strategic plan, and maybe you come back and you say, Dennis, we can do 2 this year, but we can't do 3. And then, so we're fair to everybody, and it's transparent. So that's why we tackled the readiness cost side first, as opposed to the uncompensated care. Right or wrong, but
Right.
that's open to discussion.
Because
you,
that
Dr.
is the
Ashe.
biggest barrier of getting people into the system is the readiness cost. We can't force anybody to be a trauma center, but what we can do is say, hey, we'll work with you to help get you prepared, and this is what we're willing to help fund you to get you off the ground. And once they're in the system, they usually stay in the system.
All right, Senator Walker.
Thank you all for great work. That's a real good news that you brought us today. And I look forward to seeing the map. So Navison, I think, is it a level 1 trauma center? I'm told that the Wellstar's abrupt closing of the Atlanta Medical Center not only adversely impacted Grady, but it's also had a big impact on Navicent, which then impacts my
Savannah.
district. So this is a
That's correct.
serious concern in my area, even though I'm not in a big metro area. Currently, I guess I'm understanding that your only funding is through the fines on super speeders. Is that correct?
And the firework tax,
Okay.
A portion.
portion
of
of it, portion.
So I can't even believe I'm going to bring this up because it's like the untouchable thing, I think. But do you have any idea what percentage of the traumas are auto accident related?
We do have data on it.
We have data. We can get that for you.
I mean, is it a large? I would suspect it'd be a pretty high.
It's a good sized number, yes, sir.
Yeah, it's a top 3 in almost every trauma center. Leading mechanism of injury is motor vehicle crashes
Yes.
in every single trauma center. It's one of the top 3.
We have a 4% premium tax on auto insurance and other insurance. The cities, and I guess maybe the counties, get that. But I wonder if we could shave 0.25% dedicated to trauma or something. So I'm sure ACCG and GMA will love me. Anyway, thank you.
Right. Yeah, that's what it comes down to. Sure, we understand that.
Senator Setzler on 1.
Thank you, Mr. Chairman. Appreciate you guys. I think it's been a great success story in the last 15 years. What do other states use as funding sources? I am not a fan of the super speeder as a stable funding source. I think it puts our law enforcement sort of at odds with our public sometimes. I mean, driving 86 miles an hour on Interstate 16 southbound is not, in my opinion, the clear and present public safety danger that super speeder makes it out to be. There may be a diversity of opinion on that. If we were moving away from a super speeder funding source towards something else that maybe is more stable and maybe more in line with other states are doing, what are other states doing as a funding source that we could consider moving forward in future years, perhaps?
Well, I can tell you the ones that I know about. there may be some that I don't know, Liz, so jump in, or Dr. Dunn. But like Tennessee, they have a funding source on a tobacco tax, and that's worked for a while. I don't know the numbers on that, but I'm sure with their state legislature, you could find that out. They problem with that now is that through the campaigns of smoking, fewer people are smoking, so their revenues are going down. So they're starting to look and see what they can do. I think Florida, some other states have used some red light running campaigns or tickets. They get some funding from that. One thing that had been tried here before that had failed many years ago, I forget the exact, it's probably been over 10 years ago now.
Yeah, it was over 10 years.
Was a I think it was a $10 tag fee. You mentioned MVC, motor vehicle crashes. The thinking at that time was if that's generating a lot of trauma, then a $10 tag fee. At that time on the numbers, if I remember them correctly, based on the population and the exclusion, there's a lot of exclusions on certain vehicles and things. I think it was projected to generate about $80 million, which would put us right in the box.
Right. And
But that was a constitutional amendment. It made it on the ballot, but it didn't
failed,
pass.
and it was
Didn't
14
pass.
years ago. You're right. All right, thank you. Any other burning questions? If not, we sure appreciate y'all coming and sharing the data with us, and we'll look for those maps to come. And a great success story. Really is 16% worse than now 6% better. I think that's great. Thank you so much.
Thank you.
Thank you,
Appreciate
Mr.
it.
Watson. Appreciate you.
All right, we're going from the trauma surgeons and the trauma commission to an emergency room physician. All righty. Dr. Newton, House Bill 343. We've heard this several times, and we're going to have you present it real quickly.
All right.
We have a special guest who's going to talk also, and then we're going to hear from both sides. Then we'll have you circle back and answer questions, and then we'll
All right.
take
Well, thank you,
the vote.
sir, and thank you, committee. I'm honored to be with you. I appreciate the trauma centers. I'm one who trained at a level 1 center and care for trauma patients every shift I work, but with a great team. I can tell you I was at a community hospital that went up to a level 2, and the level of care that y'all just saw. By the way, if anybody's under 45 or has children who are under 45 like me, that's the leading cause of death. So that the efforts in trauma, I appreciate you doing that, and I appreciate the opportunity to follow that up. Something else we want to do to make healthcare better for patients in Georgia. This is a quick review of House Bill 343. Everybody knows there's insurance companies, United, Cigna, and everyone. They basically do a couple of things. They find you a network of hospitals, physicians, surgeons, specialists, ambulatory surgery centers. They negotiate who's in network and who's not. Then they negotiate a price, a big reduction from the list price, and then they manage the claims. For example, if it's a $20,000 surgery bill, they may negotiate a $12,000 reduction. There's $8,000 left. When you go to pay your 20%, you pay 20% of $8,000, not 20% of $20,000. So it's a good thing. You almost have to have insurance nowadays just to get the discount off the list price. That's the strange character in healthcare. One area I didn't mention on hospitals and all is a little mini insurance company that just covers outpatient medications. That's the pharmacy benefit. So there's a mini insurance company called a PBM that does the same thing. It goes to the big manufacturers. It looks at their new drugs, their old drugs, their medium drugs, and it decides which ones will be in network, and it negotiates a dramatic discount in many cases. So this mini insurance company that's not like United and Cigna and Blue Cross that are held by the Affordable Care Act's 15% profit and overhead number, this little mini insurance company that does just the pharmacy piece has no limit on their profit. Because of that, so for example, if there's a $2,000 medicine for 90 days and you need to, and there's a $1,200 rebate, you've got $800 left, but you don't pay 20% of $800 with a PBM, you pay 20% of $2,000. So it's a challenge in the system. We have friends in the federal area that can address that. What we're here to do is see what we can do for Georgians to see how we can make it. We don't have any objection to a reasonable profit, but I do think, I'm honored to be with y'all because I think we're the ones, if there's an unreasonable amount of profit and it's hurting patients, it's our role, I believe, to step in and do what we can to protect patients. HB 343 just says, let's give the patient the benefit of at least 50% of that negotiated deduction. It started at 100% a couple of years ago and included ERISA plans, large employers, state health benefits, and others. We came off of that because of ERISA is federally regulated. State health benefits, the governor kind of controls under the executive branch and separation of powers. We brought it down from 100% to 80%. And then we brought it all the way down because of small business. We brought it down to 50% to still allow a PBM to use that other 50% of the rebate to lower premiums if they want. I'm afraid what they're doing is keeping some for profit, but one of the problems is we'll never know what that is because they use those as trade secrets for those discounts. We can't find them out, even to the extent the Department of Insurance has a law we passed, Senate Bill 313 several years ago requiring disclosure. Right now, at least one of the PBMs has over $1 million in fines for not disclosing the information. They hold this information very carefully. I'm honored to know that we're not alone in this. There are people working at this at the federal level. There are a couple of things I'd like to talk to in the future about the premium effect and how it's under 1% and how mandatory offering isn't really a solution for patients. But I know we have people that are signed up to speak. I know we have a visitor here that can give us some insight on how to help Georgia Medicare patients, which we can't really do. But I'd be honored if I could just step away and, Mr. Chairman, if that's
Yes, absolutely. So we're going to have Congressman Carter, who's been a champion of this while he was here in the Senate, and then has been a champion in Congress. Congressman Carter, you can have a seat here if you want to, or you can,
Thank you.
up there. Just as an introduction, Congressman Carter is a pharmacist, and as part of the Healthcare Doctors Caucus in D.C., and has been a advocate for patients both here and in Washington. And the floor is yours.
Well, thank you, Mr. Chairman, and thank all of you for allowing me to be here and to testify on this. This is something that is extremely important to me. As you heard, I have the honor and privilege of representing the 1st Congressional District of Georgia in the United States Congress. I served 10 years up here in the Georgia State Legislature. This is not something new that I have been just started working on. I've been working on this. And the reason why is because I was a retail pharmacist. I was the one who had to go to the counter and tell the senior citizen how much their prescription was. I was the one who watched the senior citizen as they had to make a decision between buying groceries and paying for their medicine. I was the one who had to go tell the mother how much their antibiotic was for their child and watched her in tears as she tried to figure out how she was going to pay for that medication. I set as my goal and my focus to do something about high prescription drug costs. I worked on it when I was up here. I'm working on it still in Congress. When I first got to Congress, the first thing I did was to go to the FTC and ask them to look into the vertical integration that exists in the healthcare drug pricing market, where the insurance company owns the PBM, that owns the group purchasing organization, that owns the pharmacy, that owns the doctor. The highest employer of doctors in this country is United Healthcare. They employ 9,000 doctors. They're an insurance company. Folks, this is a system that is broken, and we're trying to fix it. Finally, a year and a half ago, the FTC agreed to enter into what they call a 6B study, where they are looking at the impact of PBMs on independent retail pharmacies. Already into that, they've told us that it would take probably 2 to 5 years before they would be finished with this study. Already, they have rescinded and retracted statements that they made about PBMs in the past, about the benefits of PBMs, saying that that is no longer the case. Now, that's not me just making that up. You can look. You can look at the FTC and see what they've done. They have retracted those. Folks, 3 PBMs control 80% of the market. Now, let me preface this by saying I'm not opposed to anybody making money. I get it. We live in a capitalistic society. I own my own pharmacy for over 32 years. I wanted to serve patients, and yes, I wanted to make money too, and there's nothing wrong with that. But tell me the value that these PBMs are bringing to the healthcare system. They are not bringing value to the healthcare system. Now, we're trying to address it at the federal level. I've got a number of pieces of legislation right now we've already passed out of the Energy and Commerce Committee and out of the House of Representatives. It's over in the Senate now, where all good bills go to die, but nevertheless, it's in the Senate now. It's the Less Cost, More Transparency Act. In that, I've got two bills. One is the Drug Price Transparency and Medicaid Act that will prohibit spread pricing in Medicaid. Spread pricing, where the insurance company pays $5 for a drug but charges $10 for a drug. You've heard about spread pricing. You've heard about the lawsuits. One most recently in the state of Ohio, where they are suing a PBM because of the spread pricing that they've done in the past. The Attorney General in Ohio referred to the PBMs as gangsters. That's his words, not mine. Referred to them as gangsters. Folks, I'm telling you, this is a shell game. Now, you know, yes, the ultimate solution to this is more competition, is not to allow an insurance company to own a PBM, is not to allow a PBM to own a pharmacy. That is the ultimate solution. But I've also got another bill in the lower cost transparency, and that's the PBM Accountability Act, and this is the key, and hear me on this, okay? This is the key. This will call for more transparency. This will require the insurance companies, the PBMs, same thing, PBM insurance companies, same thing. This will require them to make available to the employers the discounts that they are getting on these drugs, where they will be able to see the discounts that they are getting. That's the key, more transparency, hence the title of the bill, lower cost, more transparency. That's what we're trying to do. Also working on a couple of other things. One of them I think is important to mention is the Protecting Patients Against PBM Abuses Act. That does this, okay, and it's already passed out of the Energy and Commerce Committee, and it's before the House right now. What that does is it delinks the pricing of it delinks the PBM compensation, I should say, from the price of the drug. It means that they can make a fee, yes, but it's not going to be based on the price of the drug, because it's the incentive there for them to dispense a higher price drug so that they get a higher percentage. That would delink this. That would take away their incentive to push more expensive drugs. I used to find it so baffling that a brand name drug would be on a formulary for an insurance company when a generic was available. And then I realized, you know what? They're getting more of a discount over here. No wonder they're putting it in there. That's the reason why. What this bill does is simple. It will make sure that at the point of sale, when that patient comes up to the counter, the same counter that I had to tell the senior citizen and I had to tell the mother, when they come up to that counter, they will be able to get that part, at least 50% of the discount. What's wrong with that? Now, you're going to say, and I've heard these other organizations say, well, that's unfair to those who aren't getting prescriptions filled, and it causes the increase in prices for everyone else. That's assuming that the PBMs are putting this towards going and lowering your health care costs and your premiums. Has your premium gone down? Mine hasn't. This is good legislation, and I hope this passes. And I want to thank Dr. Newton, and I want to thank those who are sponsoring this legislation. This is what we need to be doing for patients. Remember, it's patient care. That's what we're talking about here, patient care. We're not talking about profits. We're talking about patient care. Do pharmaceutical manufacturers need to do a better job on pricing? Yes, they do. But at least they're putting money into research and development. PBMs aren't putting any money into research and development, not one penny. They're putting money in their pockets. Again, I'm not opposed to anybody making money, but come on, guys. There was last thing, okay? There was a study done about a year and a half ago. Admittedly, it's a little aged. It was done by the Berkeley Research Group. Hear me now, hear me. This study said that only 37% of the price of a drug goes to the pharmaceutical manufacturer. This wasn't me saying this. This is the Berkeley Research Group. Only 37% of the price of a drug goes to the pharmaceutical manufacturer, which begs the question, where does the other 63% go? It's going to the middleman. It's going to the PBM. I hope you will think seriously about this bill. This is good legislation. I applaud you for doing this. I thank you for doing this. More importantly, the citizens of the state of Georgia, thank you for doing this. Thank you, Mr. Chairman, and I'll yield back.
Thank you, Congressman. Would you like to take a question?
I
or-
would love to take
All right,
questions.
so was that a rhetorical question, or did you really have one? Okay. All right, you're on number 2.
Thank you, Mr. Chairman, and Congressman, thank you for being here. I'm glad to see you've given up on D.C., passing bills up there and come down here, so we're honored to have you. But I do have a question. So, I mean, you understand how to look at things from different sides. I mean, you're an elected official, have been for a long time, and have represent a lot of
Started
people.
when I was
and-
10. Yeah.
Yes, sir. Yes, sir. And I certainly appreciate your service. I know a little bit of what it takes, so we do appreciate it. But so looking at it from 2 lenses, if this is a good piece of legislation, and I'm looking at the NFIB put out a letter,
I'm aware.
and the state of Georgia is not going to do this, and large businesses, we're not going to put the mandate on them, but we are going to put the mandate on small businesses. So looking at it from both sides, why, if it's so good, why would we not go ahead and do it for everybody involved?
I met with some of the sponsors of the bill earlier today and asked them that specific question. It's my understanding this is part of the negotiations that have been going on throughout the process. Now, should it take place? I think it's important to note also, and I'm sorry I didn't bring this up before, you know that the state of California has dropped CVS, has dropped Caremark. Even the state of California, the left coast, they have decided that they can do a better job themselves. Just this past week, Tyco dropped CVS, dropped Caremark, just this past week. Caterpillar, years ago, did the same thing. They said, we're going to do our own PBM. What is Mark Cuban doing? He's doing his cost plus because he recognizes how much of a problem this is. I don't know the answer to your question. I don't know what took place in the negotiations
enough.
throughout this process. I apologize for that. I do understand ERISA. We've made progress with ERISA thanks to the Rutledge case that was before the Supreme Court. But ERISA's always been a problem. When I was here, I remember we passed good legislation, and we did some good things up here, but it didn't apply to anything but state plans because of ERISA. And ERISA is something that they're trying to address in the Ed and Labor Committee right now.
Thank you. Good question, Senator Jackson. Witness 3. Okay.
Thank you, Mr. Chairman. So I just need some clarification around what we're trying to do here. So my understanding of a PBM, it's like I recently bought a car, and instead of me going to the dealer and negotiating the price of the car, I had a car buyer go in, and they negotiated the price, and they did all the back and forth. I don't know what magic they worked, and I'm sure the car buyer got something out of it because he did a job for me. So he got paid something for making that negotiation, and then I ostensibly got a cheaper price on the car than I would have gotten if I had had to negotiate for myself. So my understanding is that that's what the PBM does, is that they, on behalf of people who are getting insurance, they go and do all the haggling for us with the pharmaceuticals who set their prices with no regulations, right? And they're doing all the haggling for me, so they get to get a cut because they're doing a job that I can't do well for myself. But what I feel like I'm hearing you tell me today is that you want us as a state to regulate how much the middleman who's doing a job gets to get paid. And I'm not familiar in this state where we do that with any other company. Like I don't know any examples where we say, you know what, guys? You're getting too much money, so we're going to stop that and make you have to give it to the person that you're helping to negotiate for. That's what I feel like is happening here. In a layman's, I don't live in the healthcare industries. terms, so please help correct me where I'm misunderstanding that we're trying not to pay the PBM for doing a job that I can't do for myself.
And look, as I've said, and I prefaced my remarks by saying I'm not opposed to anybody making money. I understand that. But if you look at the profits of the PBMs and you look at the price of medications, what we're trying to do here and what this legislation is trying to do, what this body's trying to do, is to address high prescription drug costs. And that's exactly, you're exactly right. They are negotiating on your behalf.
Right.
The problem is, and this is where it's different, you're getting the benefit of that discount.
Right.
Prescriptions, the patients aren't getting the benefit of that discount. The PBMs aren't passing it on to the patients. They are not passing it on to, that's the difference. You hit the nail on the head. You described it perfectly. But you got the benefit of it. And that's all this legislation is trying to do, is to say, let's give at least half of the benefit to the patient, and let's do it at the counter.
Can I just follow up briefly? The actuality is I don't know that I got the benefit from my car buyer who bought it for me. I don't know. He could have negotiated for a higher price. I have no idea. I paid him because he did a job that I didn't want to do, which was he haggled with the car dealer. He negotiated, he worked something out for the car dealer that I didn't have to do. I don't know how much of a cut, I don't know how much of a profit he made. I have no idea, but I know he did a job that I didn't want to do and that I didn't feel skilled to do. So it seems to me that that's what the PBM does, is that they do a job that we as individual regular citizens aren't equipped to do, which is to negotiate with huge pharmaceutical companies who have us under a barrel because they have us over a barrel because they have the drugs that we need in order to live. The PBM is doing a job. And I feel like we are saying to the PBMs, we want to limit how much you get paid.
Well, you are right in saying that the PBM is doing a job. They are doing a job on the patients of the state of Georgia. I will assure you. Look, I'm not trying to limit anybody's ability to make money. It's a capitalistic society, and I get it. I understand that. But let me tell you, what we need is transparency. We gotta have, if we can look and see, and that's what my legislation in the Lower Cost, More Transparency Act will do. It will require these PBMs to show the employer the discount that they're getting. And what happened with the Attorney General in Ohio? They're suing them. And it's happened elsewhere as well.
Senator Lucas.
Thank you, Mr. Chairman. Let me ask you something. If I'm a small business and say I have employees and I deal with insurance company and they basically ask for a history of the folks that work for me, I get a price from them. When you talk about the PBM, I get part of that cut coming back to me, which I spread over all my employees to reduce the insurance costs that I'm paying for them. Now, will this eliminate that?
It won't eliminate it, and first of all, I would make sure that you are getting a cut of that. And that's what my legislation does in the Lower Cost, More Transparency, is to let you, as an employer, see what the discount is going to be, so that you can see whether you're getting a cut of that or not. That's what this legislation will do. But look, it's going to benefit patients. And yes, patients are the 20-80 rule, 20% probably or 80% of the cost, like anything else. And they are going to benefit from it. And the higher cost drugs, they're going to be the ones to benefit from it. And every patient will benefit from it, though. And in this case, every patient is not benefited from it.
Thank you, Congressman Carter. Appreciate that. Certainly in the hot seat there, and
That's okay.
You did a great job.
Better here in
and,
D.C.
I'm sure. Thank you for coming.
Thank you.
Thank you for
stay
sharing your
around.
wisdom. And what we're going to do is we're going to we have people who signed up for it and against it. We're going to give both sides 20 minutes, and they're going to decide how much, because it's pretty much equal. We'll take some wisdom from the judiciary chairman. That's what we're going to do, 20 minutes to each side. You only give 5 minutes to each side? Well, that's, we may limit that if we want to do, I think I remember 30 minutes the other night, but, yes. And I know that others have other committees to go to, and I do have a commitment from the committee chairman that Chairman Huffstetler says that when we are ready to vote, he's going to come back, he's going to recess, and you guys are going to come back and vote. I understand that. So we're going to continue to testify, but he is committed to me. You can go to that committee if you like, and then I'm going to call him, and he's going to recess for a few minutes, 5 minutes, and you're going to come back and vote, and then we'll go from there. Okay? No. We're going to continue on. All right. So we're going to do, why don't we do the opposition first? So, so I'm sorry. We did have somebody sign up for 181. Again, we're not doing 181 today. So I'm going to call Hunter Loggins. Let's go to the podium. And Michael Walker is also in the chute. And where's the other page? Where's the other page? I thought it was another page. Oh, here it is. Okay. All right, so we have Hunter Loggins, Michael Walker, and can Christopher Reed and Ms. Daniels did not oppose? You're for it, okay. Well, we got maybe, okay, everybody's going to have 20 minutes. No. The for is going to have 20 minutes, and opposed is going to have 20 minutes, and there we go. All right. So, time's to you.
Sure.
Are we clear on that? Okay. All right. All right. Introduce yourself. Who you represent? Thank you.
Thank you, Mr. Chairman, members of the committee. I'll be as brief as possible. My name is Hunter Loggins. I'm the state director for NFIB. We're a small business association here in Georgia with a little over 7,000 members in the state. And I've touched on this issue a little bit last year. I've met with a lot of you, and I just want to lay out the points briefly and then turn it over to our chairman, Michael. And I appreciate the congressman coming. He's been a fantastic supporter of ours. He's an NFIB member, I believe, and we are supportive of all three pieces of his legislation up at the federal level. But despite what you think, this is not a PBM bill. This is a mandate on small business. It only impacts small business. It takes away the option that most of our groups are using, which is as Senator Lucas touched on, taking the rebate and spread it around all employees to lower costs. This would mandate a single option, that point of sale system. If the state is if Georgia's the number one place to do business, they don't take away the option that most of our businesses are using and force another one, I don't believe. So if you don't want to listen to me, please listen to our chairman, Michael Walker, chairman of our leadership council here at NFIB.
Good afternoon, Mr. Chairman, ladies and gentlemen of the committee. Thank you, Hunter. Congressman Carter, Representative Newman. As mentioned, I'm Michael Walker. I'm chair of the Leadership Council for NFIB, National Federation of Independent Business. I also represent the National Association of Benefit and Insurance Professionals as the National Secretary in Washington, D.C. I'm an insurance broker. I'm also a small business owner. I urge you guys to oppose this bill for the simple fact that it is a mandate for small businesses, as Congressman Carter said, and last year, as Representative Newton said, it would give a rebate at the point of sale. If it gives a rebate at the point of sale, I, as the owner of a small business, and I do have 15 employees, and I pay 80% of the group health care costs. If I have one employee that goes to a pharmacy, whether it's CVS or you name it, and they get the rebate, that rebate doesn't come back to me. It's not spread around with the rest of my employees. It stays right there. I spend close to $60,000 to $80,000 a year providing benefits to my employees. But if the rebates now are not going to come back to me and they're going to go to that single individual, which, by the way, is using a specialty drug, which is the most expensive drug that's available. It only applies to that. It doesn't apply to generic drugs. It doesn't apply to brand drugs or preferred. It's specialty drugs, the most expensive. Then now I'm going to have to sit back and say, well, I've got to look at another plan, a plan of less quality for my employees, a cheaper plan in order to provide them with benefits. Or I got to look at it and say, hey, you guys just go to the state exchange and go and get your own plan that way. They're not going to want to do that. The other thing I like to add, that with Georgia, and we brag about it, saying it's the best place to do business, the #1 state to do business, and I believe that. However, this bill will be just another layer of onerous regulations and mandate on a small business. What we need to do is to make sure that there's a level playing field. The playing field is not level. Small businesses do not have access to capital like large businesses. Small businesses do not get tax credits like large businesses. And if this plan is so good, why is the state employee plan excluded? Why is large businesses excluded? Those that are self-insured. It sounds a little bit exclusive to me. And dare might I use the word discriminatory? Because I think there are more people on the state employee plan and in large business plans that could have access to the specialty drugs. But yet and still, you're going to carve them out and say, well, you guys are not going to get the rebate that we're pushing for down here because you're with large business or you're on the state employee plan. But we're going to give it to a small company over here that has 5 employees and maybe 1 individual that qualify for that rebate. You know, there's a reason when large companies get ready to do a test market, they come to Atlanta. They don't go to Cheyenne, Wyoming, because of the small sample size. So if this bill is really for the consumers and the end user, why don't you put it in a place where the most people can qualify for it? That would be large business. That would be the state employee plan. I have a company in Missouri. I have about 11 people on benefit, maybe 11, 15. Nobody's on specialty drugs. So putting that on me doesn't do any good. I have companies here. Putting that on me doesn't do any good because I don't have anybody to qualify for that. But yet and still, you're going to mandate that I have to enforce this type of program. That's all. Thank you.
Thank you, Mr. Walker. Then we have Cash Trivedi and Jesse Weatherington are going to tag team it. And
Thank you, Mr. Chairman. I'm Cash Trivedi. We represent the Pharmaceutical Care Management Association, which is the national trade association for the pharmacy benefit managers. I have here with me Jesse Weatherington from the Georgia Association of Health Plans. So if you have any hard questions, ask Jesse. If you want to be complimentary, just give them to me. As we have in previous years, we are opposed to House Bill 343. The point-of-sale rebate option is widely available to plan sponsors now, and this would be a mandate that they use it when it's not a plan option that's taken or utilized very often.
No, thanks to have Cash, and Don, thanks for throwing me into the bus with the tough questions. So our insurers are also opposed to this as well, which shouldn't come as a surprise, but I feel like in this committee room, many of you have been on the committee for many years, we talk about PBM issues a lot. The state of Georgia probably has some of the most stringent transparency and regulations on pharmacy benefit managers anywhere around the country. But as it's been said, this is not a PBM bill. What this bill does is it chooses between two plan designs that are currently available now, and it says you can't sell that anymore, you have to sell this one. So if you're a fan of point of sale rebate plans, I have some good news for you. You can go buy one today. Some people do if that business owner or that person who's paying the freight has made the decision that this makes sense for them, their business, and their employees. There isn't a lot of uptick on these plans. They are more expensive. Why is that? Because you can't rob Peter to pay Paul without robbing Peter first. Don't pass this bill. It is not necessary. There are point-of-sale rebate plans that are available for sale today. Do not take the overwhelming option away from Georgia consumers and ratepayers who currently are happy with the plan that they have and force them into a plan that they could buy today, but for some other reason, their better judgment, they decided against it.
Thanks so much, Mr. Wethington, Mr. Trivedi. Any follow-up there? So that's the, gave plenty of time for the other side. And so we're going to go to the folks who favor it. They didn't use up a lot of time, so we're going to maybe not be as generous, maybe not the 20 minutes. Let's do 15 minutes at the most. Christopher Reed, Miss Daniel, I may need some help with pronunciation there. Rachel Shanklin is on the pad, so those three. And okay.
Good afternoon, members of the committee, Committee Chair, Representative Newton, and Congressman Carter. My name is Christopher Reed. I am with Sister Love, which is an organization that represents women, particularly women of color with chronic diseases. One of our biggest constituents are people living with HIV. I want to tell you a little bit of a few facts specific to the disease HIV. Georgia is fourth in the nation in the number of people living with HIV, fourth in the nation. So what do we need to do to prevent HIV? We need to make sure that citizens of Georgia are receiving prophylactic coverage like PrEP, drugs like Truvada, Descovy, and Apretude. But these drugs are considered what the gentleman earlier mentioned, specialty drugs. I specifically take a PrEP drug, which costs $4,000 a month retail. I pay $1,200 after my insurance benefits come in. We need to make a change by passing House Bill 343 to make sure that people in Georgia are not exposed to HIV or to prevent exposure to HIV. I want to say that these prophylactic drugs are 99% effective at preventing HIV transmission. So what are these PBMs? One, they restrict patient access to specific rebates that patients are really entitled to. They would reduce drug costs. We also need a greater transparency with respect to the PBM so that we better understand what we're paying as patients and what PBMs and insurance companies are receiving as revenue. I don't live with HIV, but I live with 15 other chronic diseases, and I take 3 specialty drugs, which means I'm paying out of pocket tremendous amounts of money per month. So what I ask is that you pass House Bill 343, that you provide 50% of the rebate to patients, and you increase greater transparency with respect to PBMs. Thank you very much.
Thank you so much.
Good afternoon, everyone, Chairman and committee members. I'm Alisa Daniel. My name is Alisa Daniel, and I'm a lupus survivor, a social worker, and I'm a Georgia State graduate student. Last September, I lost my disability and health insurance and found myself having to pay out of pocket for medication. Finding the right medication to treat lupus can be a complicated process. Previously, I was able to take a cancer drug called rituximab, which is also a specialty medication to treat my lupus, which actually put me in remission for a few years. However, by the final time I received the infusion, I was allergic to the medication and immediately broke out in hives, so I was no longer able to take that medication. This removed the drug once worked as an option for future treatment. Since my doctors have worked diligently to find a combination of medications to treat the symptoms that I deal with on a daily basis, specialty medications such as Cellcept, Plaquenil, and Benlysta are the first two medications to cost me $50 out of pocket per month using a pharmacy discount code from GoodRx, which is for people who don't have insurance and typically can pay out of pocket. However, Benlysta, even with the GoodRx help, cost me $4,600 per month. Benlysta is currently one of the only FDA-approved medications that have been developed and approved to treat lupus. Because of the monthly cost of $4,600, which I am not able to afford as a graduate student, this eventually landed me in the hospital with acute renal failure for 2 weeks. I was using a walker and more medication than I had started with. By the end of my hospital visit, I had totaled a $30,000 hospital bill, much more than the cost of the medication that would have prevented this, and still no way to cover my prescription of $4,600 a month. To this day, I still have trouble getting this medication, and with a baby due in April, access to this medication is more important for me, for my health and my family. Currently, there are 55,000 lupus patients in the state of Georgia alone. I ask you to take this into consideration when voting for House Bill 343 and lowering the prescription drug costs. Thank you.
Thank you, Ms. Daniel. Rachel Shanklin, and then Heather Breeden and Dorothy Leon Glasser.
Thank you, Chairman Watson, Vice Chairman Kirkpatrick, and members of the committee, and Dr. Newton for bringing this bill to light. My name is Rachel Shanklin, and I am the Georgia Director for an organization called Small Business Majority. We have a mission to empower America's diverse entrepreneurs to build a thriving and equitable economy. So I would like to tell you first and foremost that access to affordable health care is a top priority for small businesses, especially since it's often the highest expense for employers outside of payroll. However, lowering prescription drug costs can ease the financial burden on small businesses that provide health insurance to their employees, enabling them to invest in other areas of their business. House Bill 343 would help rein in rising drug costs by requiring that pharmacy benefit managers pass 50% of the drug rebates on to the patients who are buying the drugs. By lowering prescription drug costs for patients, this legislation will actually benefit small business owners, in turn by reducing healthcare expenses for themselves and their employees. The legislation can also help lower costs by imposing penalties on pharmacy benefit managers for unfair practices and contributing to a healthier business environment. As a result of this legislation, small businesses that can offer affordable health insurance plans with lower prescription drug costs may have a competitive advantage in attracting and retaining talented employees who are looking for a robust benefits package. I'll also mention that this can be particularly valuable in industries where talent retention is a significant concern. What's more is that when prescription drug costs are lowered due to the 50% rebate pass-through, employees may find it easier to access necessary medications. Improved access to medication can lead to better health outcomes and potentially reduce sick leave and absenteeism among employees, increasing productivity. Despite what health insurance companies, pharmacy benefit managers, and opposition of this bill claim, this legislation will not drastically increase healthcare premiums. One study by Milliman demonstrated that even if health insurance companies were required to share all the negotiated rebates with patients, premiums would increase at most 0.6%, while some patients could save nearly $1,000 each year on their medicine costs. Fixing this broken part of the system and sharing these savings will give patients immediate relief and help them better afford the medications they desperately need. This type of legislation is also strongly supported by small businesses. Small Business Majority scientific opinion polling of small business owners has found that the most popular healthcare policy proposal among respondents is to bring down the price of prescription drugs, with 90% in support. What's more is 93% of small business owners believe that lowering healthcare costs should be a top priority for policymakers. House Bill 343 presents an opportunity to enact meaningful reform that will put money back into the pockets of working Georgians and small businesses. Thank you for the opportunity to comment on this important issue today.
Thank you, Ms. Shanklin. Heather Breeden, and then Dorothy Leon Glasser, Melissa Raybold is on deck.
Chairman Watson,
Yeah.
first supports the bill. I'll wait my time.
Okay, thank you. Okay, so y'all are off mic, so I'm gonna just say Georgia First and, I'm sorry. Georgia Pharmacy Association supports the bill, and Georgia First. So we're down, excuse me. Laura Colbert will be the last one, I think. Okay. Oh, Miss. She supports the bill, has nothing further to add other than that Georgians for a Healthy Future are supportive. Okay. Did we get Dorothy Leon Glasser? She is on her way. Okay.
Thank you, Mr. Chairman. Thank you, committee. I've been here before. This is my third year, going on fourth year, to try to pass HB 343. As you know, I'm the executive director of the Advocates for Responsible Care, and I lead the Georgia Coalition for the RX and Reach Georgia Coalition. We're 48 members strong of medical professionals, advocacy organizations, and concerned citizens who want to be able to access affordably their prescription drugs. I want to make one thing very clear. This bill was never proposed as a mandate. I don't know how it got twisted in today's discussion to be a mandate. This bill was created because rebates were created to give back to the patient at point of sale to ease the burden of high prescription drugs. That is the premise of this bill. It's always been the premise of this bill. We want to also clarify something that was said today. The patients do not hire PBMs. They're hired by the insurers. So we have no say in their negotiations and what they do to bring the profits back to not only their pockets, but the pockets of the insurers. They do not have patients' best interest at heart. We have to come to our legislators to ensure that the patients get the rebates that were created for them by the drug manufacturers. I want to also thank Congressman Buddy Carter for all the work that he is doing on this issue and helping patients to get the prescription drugs that they need, and also to oppose and make sure that we have transparency in these transactions. We hear calls every day from patients who need these drugs. The drugs we're talking about today have no generic substitutions. They are specialty drugs because the people who need them are seriously ill with major diseases that have multiple complications and premorbidities. There is no other drug available to someone who must need one of these drugs. And as a healthcare professional, I have to say I don't know how we got here. I don't know how we got here that profits being made are interfering with doctors prescribing the right drug for the right disease at the right time to the right patient. I hear we have MAG and other medical organizations on our coalition who are absolutely baffled that they cannot give the patients the drugs that they need. We started negotiating this 3 years ago at 100%, just like Arkansas passed and Virginia passed at 80%. Must Georgia be last again So we were told 100% would not pass. The governor preferred us to go down to 80%. We negotiated 80%, and then they turned around and said, no, we don't want 80%, we want 50%. The patients have exhausted their ability to compromise on their health and their safety. And now, once again, we're being told, no, we're not going to give you 50%. This was created for us to help ease that burden. As a lupus and cancer survivor, I can tell you it makes the difference between me standing here or being on disability. We need you to please pass HB 343 at 50%, which is the least that patients can possibly have. We cannot give up this fight, and we hope that you're in the fight with us. Thank you. And I'm sorry. Thank you again, Chairman, for hearing us on this bill for 3 years in a row. And we also want to thank our committed and devoted bill sponsor, Dr. Mark Newton.
Ms. Leona Glasser, Senator Ulrich, you got a quick question?
Yeah.
My brother's prescription for the disease that's going to kill him someday, pulmonary fibrosis, idiopathic pulmonary, and it's $96,000 a year. If he weren't able to negotiate, they're very capable, you know, they're very high performing and go all over the country looking for cures and working with a network. But it's it's a rare disease, and it's massively costly, and another drug won't do the trick.
Right.
And so I'm seeing very up close as a sister of a patient with that condition, why this is a good and timely bill.
Thank you. Thank you so much. Any other questions?
We got number 10, Senator Hatchett.
Thank you, Mr.
Yes.
Chairman. I've got a quick question, because I know this is a 6-page bill, but I think the meat of the bill comes down to about, 3 or 4 lines? And you're the first person that's come up here that said this is not a mandate. And I'd like to expand a little bit on that. Could you explain how this isn't a mandate?
First of all, I don't think this body, and certainly patients, don't have the ability to decide what goes into ERISA or any other group of insurance. That's way beyond what we're doing here. We're looking at patients who have insurance, that they be able to get the rebates that were created for them. It's not mandating that they get it. It was created. The negotiation happens between the pharmaceutical industry and the insurers.
And just to follow up, my understanding is this is not mandating rebates. This is just saying if there
The amount.
is a rebate,
Yes. This is
then
the amount of rebate.
the rebate has to be passed, I guess the benefit has to be passed on to
Directly to
the
the patient at the point of sale.
But this does not require anybody to give any type of rebate at all.
That wasn't already there. Right. Right. It's not requiring you to give a rebate unless that drug says that there is a rebate attached to it.
Okay, and if I can follow up just one more.
Okay.
So, and this is, I'll be honest, this is one of the toughest bills that I have had to wrap my mind around. And
Well,
I've been-
buckle
and
up.
I've
We
got
got a few
really
more
good
coming.
friends on both sides. Good friends on both sides, back home and in this building. Luckily, my dad hasn't called me on this one yet. But my question is, if I have people saying this is going to cause me to charge or it's going to cost my employees more in premiums, is there data to support that? 'Cause
Absolutely not. We have never seen premiums increase because of specialty drugs. And I will quote from a CVS white paper that says, returning rebates to patients actually resulted in overall plan savings.
is there data to support that?
Yeah, it's a white paper.
I mean, but we haven't gotten any of that. I'm just saying
I'm sorry,
there's people on
last
both
time I
sides.
testified, I gave an evidence-based paper. I will be happy to send that to you.
Because
All right.
I know there's good arguments on both sides, but
Yeah.
I haven't.
I appreciate that. Thank you.
Thank you, sir.
Appreciate you coming down. We'll give the chairman a couple minutes. I think we're even going to put you on the clock for 2 minutes. How about that?
All
2
right,
minutes,
thank you.
2 minutes discussion, and then if there's, hopefully there are no more questions, but if there's a burning question you can't keep or can't answer or we can't discuss, then we're going to vote. All right.
All right.
Got
Quick,
2 minutes.
quick thing, on your example with the automobile, Senator, it was exactly right. If the negotiator told you it was the list price and that was all they could get, and then they pocketed the discount they got, that would be them acting like a PBM. They would have told you the price is the list price. You would have paid it, or borrowed the money and paid 10%, whatever you did, and they would have pocketed the difference. That's what the PBM does. Second off, we do have mandates for maternity care, for mental health. You can't sell a cheaper policy and exclude pre-existing conditions. We don't allow that anymore. We want Georgia families, if they have insurance and they pay through it themselves or through their employer, we want them to have it. The biggest question is this a significant amount for insurance companies, for small businesses or medium-sized businesses or individual plans? We have a lot of studies. The best thing in your packet here is the one state that did just pass this in 2023. Arkansas passed this. They did 100% pass through the rebate. So the national average went up 4%. This is from 23 to 24, the premiums that just came out. Georgia's premiums went up 7%, and we didn't change anything. In Arkansas, which did add a PBM pass-through to the rebate to the benefit of the patient, went up 1%. Those are the real facts. And I think someone with kidney disease mentioned, or lupus mentioned, an expensive hospitalization when you don't comply with your medicines. This is an opportunity for us to make a difference for Georgia patients. I have the blessing of being able to do that whenever I go to work with a great team. This bill failed by just a single vote last year, failed to move forward. It can move forward with just a single vote change. I think it's something that we can do. It's time for us to do it. I wish we could take care of Medicare patients and ERISA and a lot of other large employers too, but those are outside the purview of the Georgia Department of Insurance. I think this is a good bill. I think together we can make a difference for Georgia patients, and I sure would appreciate, let's move this forward to the next step so we can make a difference for those who we can help.
Well, I appreciate that. And you did hold 2 minutes, and Senator Setzler says he has a burning question, so he is on one. Is that correct?
Yes, sir. Thanks, Mr. Chairman. To my friend and Dr. Newton, I supported this last year, but I had anxiety last year in doing that because I am concerned with picking winners and losers. I'm concerned about small business versus SHBP. I know there's some discussions and agreements that have been had. I don't know why this doesn't apply to everybody. I'm sensitive to, and I don't say this just as a small business owner myself, fairness writ large. I didn't have a chance to ask any of the small business groups if they would support this if this did apply to everybody.
They didn't support it then. The PBMs wanted it to go away when it was ERISA and large groups.
Yeah.
They wanted the large groups taken out. Then SHBP is similar to a large group who has a third-party audit of theirs, so they actually can demand pass-through understanding and at least transparency. Small and medium businesses can't do that, and I think that's where the profit margin of close to 30%. By the way, we do limit the profit on insurance companies. Almost everyone has to get an insurance policy to survive in today's world in America. We do limit it to 15%. That's the MLR, or the medical benefit ratio. Federally, that's the ACA plan that limits your profit to 15%. State level, on our Medicaid CMOs, we have them at 87% for most of them. We want them to spend the money not on profit and overhead and administration. We do limit their profit because it's almost a utility. It's almost a product every family has to buy. And so because of that, we would like the same role to apply to PBMs, to the mini insurance company that just handles your pharmacy. Don't let them get a 30% or 60% profit. Let them share half that with the patient, and they can still share half with the small business owner. That was one of the reasons we were compromised and brought it down.
There we go. Gotcha.
I support the consumer interest here. I think the consumer does get screwed in this. And I think when people take a job, they have health insurance, whether it's a small company, big company, SHBP, they expect that healthcare is going to kind of be there for them. It's going to lower the cost. I strongly support the bill in that sense. My question is, and I know you're not looking for amendments, but my thinking is, my mind immediately goes to the place of, if on January 1, 2028, we made it apply to everybody, we made it apply to the state health benefit program. So it's, we create this circumstance that only affects the smaller businesses for the next 4 years, and then starting the budget cycle of 2027, be a different governor, different administration. At that point forward, from a budgeting perspective, this would apply to people in the SHBP. I think school teachers ought to get this benefit. The bill as it is today does provide a benefit for people in smaller systems. I think school teachers ought to get this, and it ought to apply more broadly than what you're doing. I think you're doing a very good thing, and it ought not be limited.
I think we'll see, like in Arkansas, instead of going up at the national average, our premiums may go up a fourth of the national average increase. So I think it's a good opportunity, and I think we'll have the evidence then to spread it to benefit more
All right,
Georgians.
Okay, any more burning questions? No, I see no burning questions. I am happy to entertain a motion. Senator Orrock.
I'd like to move due pass.
I'm sorry, I didn't turn on your mic. I heard you say you'd like to move due pass.
HB 343.
HB 343. And we got a second, Senator Huffstetler. Any further discussion? Hopefully, I think we've discussed it out. There we go. All right, so all those in favor of House Bill 343, LC 33, LC 339467S, all those in favor, raise your hand. 1, 2, 3, 4, 5. All right, those in favor, 1, 2, 3, 4. That's 5. All those opposed?
You know better.
1, 2, 3, 4, 5, 6,
But you know.
7, 8. 8. The motion does not pass, and
Recognized for a motion?
yes.
I want to tee up this as a potential motion for members to consider. Would there be an interest of people who don't support passage of the bill as it stands now? If we were to insert on line 61, except that such terms shall not apply to, if we said, except that until January 1, 2028, such terms should not apply to. In essence, this bill would be in effect for 4 years, and then on January 1, 2028, it would apply to everybody. Leveling the playing field.
I understand your thoughts, and I appreciate that. That's time for a later discussion. I think we discussed it today. Thank you for your thoughts, though. Posture is we have a meeting on Monday at 2 o'clock, and we have House Bill 181 that hopefully will be singing Kumbaya relating to the amendment or not. We'll vote on that, and we won't hear any more hearing on that bill.
377.
And we have a departmental building, bill, Senate Bill 377. Thank you so much. Meeting adjourned.